3 centimeters. When using ultrasonography, watch for the shadow of the needle to appear on the image. The needle can then be followed into the vessel with ultrasonographic guidance. When the internal jugular vein is entered, a flash of venous blood is obtained. Because of the collapsibility of the vein, this commonly occurs while the needle is being withdrawn, which tents the vein. Once the needle has entered the vessel and steady blood return has been obtained, maintain a steady position of the needle with the non-dominant hand while gently removing the syringe. Dark, non-pulsatile flow confirms access to the vein. Once the needle is in the vein and free flow of blood has been obtained, employ the introducer. Using the introducer, advance the curved end of the guide wire through the needle. An assistant should watch the monitor, looking for signs of arrhythmia during advancement of the guide wire. Arrhythmias indicate that the wire has reached the heart. If arrhythmias occur, withdraw the wire slightly until they cease. After the guide wire has been inserted, withdraw the needle, leaving the guide wire in place. As the needle exits the skin, be sure to grasp the guide wire at the skin. At this point, only the wire remains in place. Using an 11-blade scalpel, make a small superficial incision at the entry point of the wire to facilitate passage of the dilator through the skin. Be careful not to cut the wire. Place the dilator over the guide wire, being certain to maintain control of the wire at all times in order to prevent a wire embolism, and advance the dilator 1 to 2 centimeters by holding it close to the tip and rotating it. Be careful not to introduce a bend or kink in the guide wire. Remove the dilator, anticipating increased bleeding. Maintain a grasp on the wire. A 4x4 gauze pad can be applied to the insertion site to minimize blood loss. Once again, only the wire remains in place. Now, feed the catheter over the guide wire, being certain to maintain control of the external end of the wire before advancing the catheter through the skin. This usually requires that the wire be pulled slightly out of the patient until the external end of the wire extends out of the catheter hub and can be grasped. While grasping the external end of the guide wire, advance the catheter over the wire using a rotating motion. If resistance is met, the track may not have been adequately dilated. Remove the catheter and try again to insert the dilator. Insert the catheter to a depth that places the tip at the junction of the superior vena cava and the right atrium. Remove the guide wire and check for blood return in all ports. Flush all ports, place caps on the hubs, and secure the line in place. Apply a sterile dressing. Obtain a chest X-ray to assess for proper placement and to assure that no hemothorax or pneumothorax has occurred. All sharps should be properly disposed in approved sharps containers. Scalpels should be retracted into their protective sleeves. Needle stick injury can be minimized by using needle lock devices found in most commercial central line kits. There are some common problems that can occur during placement of a central venous line. Puncture of the adjacent artery is usually obvious if pulsatile or bright red blood flows into the syringe. However, in patients with hypotension, hypoxemia, or both, it may be difficult to differentiate placement in the artery from that in the vein. The possibility of this complication should be recognized before the wire is inserted. If the catheter is in place and its location in the artery is suspected, the line should be connected to a transducing system. Pulsatility or any pressure higher than 30 millimeters of mercury or approximately 30 centimeters of hydrostatic pressure is probably arterial in nature. Ideally, transduction should occur before the wire is passed and should be performed routinely. If arterial puncture occurs, remove the catheter and place firm, direct pressure on the site for 10 minutes or until there is no further bleeding. Occasionally, air may be aspirated into the syringe. If this occurs, check the syringe to be sure that the needle or catheter and syringe are firmly attached. If so, immediately remove the needle or catheter since there may be a pneumothorax at that site. This is especially important if the patient is having symptoms of increasing respiratory distress. Immediately obtain a chest X-ray and insert a chest tube if necessary. For persistent bleeding at the catheterization site, apply direct pressure and check the results of coagulation studies. Replace blood products as necessary. If bleeding continues, there may be an arterial or venous tear that requires surgical exploration. In any of these circumstances, do not attempt to place the line at the opposite site, since you risk contralateral pneumothorax and further respiratory compromise. If arrhythmias are seen on the monitor, the line may be in the heart, in which case the line will need to be pulled back. By approximating the necessary length of the wire before catheterization and confirming its placement with a chest X-ray, this problem can be avoided. Always be sure to work within a sterile field when placing a central venous line, and to keep the site clean after placement to prevent local or systemic infection. If the wire will not thread through the needle, you may need to adjust the placement of the needle, since it may have inadvertently been advanced during manipulation. If so, adjust the needle and re-aspirate to be sure that you are still within the vessel. If you are unable to re-establish blood flow, remove the needle and start over. If the vein has been difficult to cannulate, the presence of a clot in the needle will further complicate assessment of whether the vein has been successfully entered. In this circumstance, remove the needle and flush it thoroughly with saline to clear it before reattempting placement of the line. A sterile dressing should be placed on the insertion site. The dressing should be changed daily, and whenever blood or liquid accumulates or it loses its seal. In order to minimize the potential for infection in the central venous line, the following precautions should be observed. The number of times the line is accessed should be kept to a minimum. Each time the line is accessed, this should be done under either sterile or clean conditions. The access site should be prepared with an alcohol-based solution. There should be a daily assessment to determine whether the central line is still needed, so that it can be removed as soon as it is no longer necessary. A central venous line is a convenient and often necessary tool in the treatment of the critically ill patient. However, one must always be aware of the potential for infection.